Today we're going to talk about care of the patient with stomach disorders. We're going to be talking primarily about gastritis and then peptic ulcer disease. Our student learning objectives are to teach patients on how to promote GI health and prevent gastritis. We're going to teach patients how to enhance their nutrition, promote digestion, and minimize discomfort. We're going to implement nursing interventions to minimize stressors, prioritize care and educational needs of patients with stomach disorders. First, let's talk about gastritis. Gastritis is the inflammation of the gastric mucosa, or an inflammation of the stomach lining. There are two types. There is both acute and chronic. Acute gastritis is early manifestations are a thickening and reddening of the mucosal membranes, and they have very prominent folds. Regeneration and healing usually occurs within days. Chronic, which is where we're going to spend most of our time today, it appears to be patchy and diffuse. The inflammation of the lining of the stomach is real patchy, and it's kind of diffuse in the reddening areas. As the disease progresses, the walls and lining of the stomach thin and atrophy. With progressive gastric atrophy from chronic mucosal injury, you lose the function of the acid-secreting cells, which are very crucial in the absorption of vitamin B12. With that being said, when the vitamin B12 stores are depleted, pernicious anemia results. Also, chronic gastritis increases your risk of gastric cancers. So what are some of the causes of gastritis? Well, the Heterobacterial pylori, or H. pylori, the gram-negative bacterium, can be the cause of acute gastritis. Long-term NSAID use puts patients at high risk for acute gastritis, inhibiting the prostaglandin production in that mucosal barrier. So as you can see, a lot of things can cause gastritis. Health promotion is going to be vital with these patients, and prevention of recurrent gastritis and to control chronic gastritis. Ways that we prevent are listed in chart 55-1 on page 1104. It discusses eating a well-balanced diet, avoiding smoking and alcohol, to have regular exercise to maintain peristalsis, and stress reducing techniques. All are very important in gastric health. And you can read the rest of that slide there. Assessment and noticing. I want you to make sure you pay particular attention to chart 55-2, where it talks about the difference between acute and chronic gastritis. Acute is a rapid onset of epigastric pain and nausea and vomiting. They can have gastric hemorrhage. Chronic is usually more vague. Reports of epigastric pain. They'll have anorexia and nausea and vomiting. So make sure that you look at the key features in chart 55-2. Symptoms of acute gastritis can range from mild to severe. You want to always assess for abdominal tenderness and bloating. They may have hematemesis or vomiting of blood, or melia, which is dark, sticky feces as evidence of blood in the stool. They look very tarry. If they have frank blood in their stool, that's usually a sign of a lower GI, because that's the port wine stools have to be lower. The stools from gastritis or a perforated ulcer are going to be coffee ground like, and they're going to be dark, sticky, very dark in color. So what do we do for these patients? They are usually diagnosed with an an ECG, is the gold standard. Cytology examination can either confirm or rule out gastric cancers. And a rapid urinase testing for hydrochloric infection are usually the way that they'll tell. A lot of times on these patients, the EGD is the gold standard on how they look for gastritis. So what can we do for these patients? We treat the cause. For acute, we treat signs and symptoms and complications such as bleeding. For chronic, they're treated with histamine blockers, mucosal barriers, antacids, proton pump inhibitors, and antibacterials if H. pylori is present. What do we need to teach? We need to talk to them about their use of over-the-counter medications. They should avoid NSAIDs, spicy foods, and caffeine, and other foods that are very high in acid. These patients are usually not seen in the acute care setting unless they have an exacerbation. Most of the times these patients are treated at home. So what you want to do is make sure that you're eliminating the causative factors. You're going to treat the cause with these patients. Other medications that they use are the histamine 2 receptor agonists such as Pepcid. They use proton pump inhibitors such as amoxicillin or Prilosec. Both of those are used quite often with these patients. Other things that we're going to do is teach them to avoid foods that will irritate their gastritis. Okay? So that will also be helpful for them to avoid foods such as spicy foods, caffeine, coffee. Any of that is going to increase their risk of flare-up with gastritis. We're going to move on to peptic ulcer disease. It starts in your book on page 1107. Peptic ulcer disease is a mucosal lesion of the stomach or duodenum. Peptic ulcer disease results when mucosal defenses become impaired and are no longer able to protect the epithelium from forming a defense against acid. So basically, it's where the acid has eaten a lesion in the stomach, and if they continue, they can actually perforate. There are 3 types of ulcers. There are gastric, duodenal, and stress ulcers. Stress ulcers are the least common type. Gastric ulcers usually develop in the antrum of the stomach near the acid-producing mucosa. So then you can have breakdown of the mucosal barrier can occur, and this is usually from an H. pylori infection. Okay? Gastric emptying is often delayed in patients with a gastric ulceration. This causes regurgitation of duodenal contents, which worsens the gastric mucosal injury. Most duodenal ulcers occur in the upper portion of the duodenum. They are deep, sharp, demarcated lesions that penetrate through the mucosa and submucosa. The floor of the ulcer consists of a necrotic area residing of granulation tissue and surrounded by fibrosis. The main feature of a duodenal ulcer is high gastric acid secretions. Although a wide variety of secretion levels are found, you will always see that they will have higher levels of gastric acid secretions. Stress ulcers are acute gastric mucosal lesions occurring from an acute medical crisis or trauma, such as sepsis or head injury. In a patient who is MPO for surgery, gastritis may lead to stress ulcers, which is one reason where they've started trying to feed the stomach as soon as they can in trauma patients and in head injury patients. And you'll talk more about that in your next class. But just know that stress ulcers a lot of times are because of keeping people NPO for too long of a time. A lot of times they'll put them on IV proton pump inhibitors or IV H-histamine blockers to keep the acid levels in their stomach low so that they're able to not cause these stress ulcers after traumatic events. Assessment. You want to make sure you assess risk factors, history of H. pylori infection or GI surgeries. You want to look at both their prescription and over-the-counter drugs. Gastric ulcers usually worsen with food, where duodenal ulcers are sometimes relieved with food. Most common complications of peptic ulcers are hemorrhage, which is the most serious, perforation, pyloric obstruction, and intractable disease. We'll come back on the next tape with interventions.